Hello, this is Jason Chandler, and I'll be doing a lecture on leukemia and lymphoma for an update on topics that would be necessary for OCN. We'll be concentrating mainly on leukemias, lymphomas, and also talking about multiple myeloma. So we'll break it down into the acute leukemias and also the chronic leukemias, and then CLL, which really follows under the lymphoma group, and take them one at a time. So when talking about all the different leukemias and lymphomas, sometimes the nomenclature can be a bit confusing when you have patients with CML, AML, ALL, and CLL. What are all the A's and M's and L's talking about? And if you see here on a continuum, the more chronic forms would be slower growing. These would be leukemias that do not usually cause acute death. Someone doesn't die quickly. They usually have an indolent course and grow very gradually and are fairly treatable. On the other continuum, it's acute leukemias, and these are usually the kind that people become acutely ill and have to go to the hospital for treatment. If they're not treated, oftentimes they only have weeks to sometimes a month to live. That's the acuity of the leukemia. And then if you look at the cell type or the cell of origin, if they're more myeloid in nature, these would be more like the neutrophils or monocytes versus lymphoid in nature, the lymphocytes that you see on a normal CBC. So a chronic lymphocytic leukemia is slow-growing, indolent, mainly lymphoid or lymphocytes. This actually, although it's called a leukemia, falls under the non-Hodgkin's lymphoma, is considered a lymphoma, but it is slow-growing. Then there's chronic myeloid leukemia. This is a blood cancer that is treatable with agents we'll talk about, including Gleevec. It's very slow-growing usually, and until it progresses, and at times can change into an acute myeloid leukemia. These are leukemias that grow very fast, where people have to go to the hospital and get chemotherapy for 7 days. And then we'll talk about the acute lymphoblastic leukemia. These are lymphoid and acute. These are most common in children, but also happen in adults. So when we talk about these, 90% of leukemias that occur are in adults. If you look at the breakdown and distribution here, CLL and AML are more common. CML and ALL happen about 1/3 as often. These are new cases in the United States. But then if you look at the number of deaths per year, very few patients die of CML anymore because we have such good agents. With CLL, the numbers are low as well. For ALL, it's a little, isn't quite true for adults. This is such a good number mainly because mostly kids have ALL and they do so well. So for the adult population, the death rate per case would actually be much higher. And then for AML, you can see how poorly people in general do. Out of 14,000 cases, usually about 10,000 patients are dying of AML each year. So that's a pretty important slide to kind of break down all the different types of leukemia and how well they do. So we'll take ALL, which is acute lymphoblastic leukemia, first. So if you look at this in the younger age population, this is actually in the UK, age 0 to 4 or 5 to 9, you can see the rates of ALL are extremely high, and they drop until you get into the early teens and 20s. And then late in life, there is a slight bump up but it's dwarfed by the younger age population, which are most of the people that have the disease. So even back in 1964, these are patients that are younger, 15 years or younger. You can see this was the rate of survival at 5 years for ALL in the childhood population. It's terrible at 3%. And with some of the St. Jude protocols and other combination chemotherapies, you can see how the cure rates have gone from 57, 66, and now they're up to around 90%. This is only in the childhood population. These are some good rules of thumb, though, and you think about as the age increases, in general, patients do worse. So for those younger populations, they do great, and that's why that previous slide showed such a good survival rate for ALL, because most of them are kids and most of them do well. But for the patient populations that we see, which are sometimes the young adults and those over 65, you can see how horrible they do. I mean, up to around 15% 5-year survival, or even 40% in these populations. So this is more specifically for, this is not specific for ALL, but all leukemias. We know that radiation exposure, any kind of damage that can occur to DNA can cause these. And what we think happened is there's a stem cell present, a leukemic stem cell somewhere in the body that's making normal blood, and then it develops a mutation which gives it an advantage where it doesn't die, or it can expand and proliferate. And so the things that can cause DNA damage are what would be the initiating factor. The people around Hiroshima had radiation exposure. There's some agents like benzene, formaldehyde. People that have had chemotherapies, like for previous breast cancer, are at increased risk for developing leukemias, acute myeloid leukemia, at a later date. There are some reports of certain viruses. This is an HTLV, a specific virus, that can actually infect cells and cause DNA damage, which lead to a certain type of leukemia. There's different inherited disorders where people have DNA repair mechanisms damaged from birth, and they're at risk for multiple problems, like Down syndrome. They're at increased risk for developing AML. Also Fanconi's anemia, ataxia, telangiectasia, their DNA damages very easily, thus they're increased risk for this. And then finally, cigarette smoking is potentially a risk factor for AML and CML specifically. So if a patient has a suspicion for either ALL or AML, what we're talking about is in the bone marrow, the location in the large bones in the hips, legs, arms, the marrow space. This is where most of the stem cells live, where most of the red blood cells, white blood cells, and platelet production is taking place. So when we're doing a bone marrow biopsy, we're getting a sample of this. And so to diagnose these leukemias, at times the blasts or the leukemia cells will jump into circulation and we'll be able to detect them, but oftentimes they stay just here in the marrow. And as they expand and expand and expand, they take over so that there's less room for red blood cell and platelet production, which is why these numbers usually go down as people are having progressive leukemia. So when you diagnose ALL, you want to do a bone marrow biopsy, get a sample. 25% of these have a specific chromosomal abnormality called the Philadelphia chromosome, and this is a poor risk factor, so you always want to check FISH and cytogenetics to look for these and other risk factors. To be officially leukemia, there has to be greater than 20% blasts in here. And for certain types of ALL, you also would like to do staging. Although it's not truly a lymphoma, ALL can be in lymph nodes, and so a CT of the chest is important. They have a very high risk of the cells getting into the spinal fluid and around the brain, so a lumbar puncture is necessary. And oftentimes we give chemotherapy through the lumbar puncture to try to reduce the risk of it coming back in around the brain. Finally, for males, especially younger males, one of the sanctuary sites where ALL can go but chemotherapy doesn't go well is in the testicular area. So a testicular exam is important to make sure there's no ALL mass noted, massive cells, or lymphoid aggregate. Anytime we're doing induction chemotherapy for ALL or AML, you're using anthracyclines or potentially cardiotoxic drugs. So we'll always need an echocardiogram. And if you're worried about tumor lysis, the tumor drying so quickly that the cells lyse open and release uric acid, potassium, which can be fatal if they rose too quickly, we want to check these labs and make sure the patients are well hydrated. So for ALL specifically, when we do a stratification of how patients do, patients over 35, as young as that is, really don't do very well. You saw on the earlier slide, it's really the young patients that do great. And then over 65 is another cut point where they do very poorly. There is a specific chromosome abnormality I mentioned earlier called a Philadelphia chromosome. And just to explain what this means, this is a normal chromosome 9 with DNA on the short arm and long arm. This is a normal chromosome 22. And for some reason, there's this place where these cross over, and part of the DNA from the long arm of 22 and the short arm of 9 switch, and you get a 9-22 translocation. And that basically puts a grow signal next to a cell for making white blood cells. Not exactly, but that's what happens. And this signal tells the leukemia cells to grow faster. So if this develops, they have a much higher risk of recurrence, and they're much more likely to relapse. Other risk factors when we're looking are a white blood cell count. The higher it is for ALL, the worse patients do. Greater than 30,000 is a poor prognostic factor for B cell type, and greater than 100,000 for T cell type. Cytogenetics are basically these different abnormalities in the DNA, and sometimes there's deletions on 11q23. This gene is called the MLL gene. Or if patients have hypodiploidy, that means there's loss of chromosomes. And complex cytogenetics, which would be multiple. Some consider 3 abnormalities, some up to 5 as complex. But the more abnormalities, the worse people do. So whenever you have a new patient with ALL, there's different phases of therapy. First, you give them induction, which is usually in the hospital and very intensive chemotherapy, with the goal of trying to get the leukemia to disappear from the bone marrow or from the bloodstream. Once you've done that, you move on to consolidation. If all you did was induction chemotherapy, almost 100% of the time, the leukemia would come back. So the consolidation helps kill off more resistant tumor cells. If it's given frequently enough and often enough, hopefully you can kill off every last leukemia cell until they can potentially be cured. So ALL can be a curative disease. Finally, a maintenance arm is given where very small doses of oral chemotherapy are given, like on a weekly basis or sometimes a daily basis, for up to 2 to 3 years. And this is to kill off the very last bit of clones. So for patients greater than 40, a common regimen would be hyper-CVAD, a regimen that was developed at MD Anderson. And this is hyperfractionated cytoxin is what that stands for. And then these each have different chemotherapies associated with them, which are given on an alternating regimen where you give one and give the other. It's a total of 8 cycles. It takes multiple months. There's newer agents like Rituxan, which can be used, which target them if they are CD20 positive. And if they have that Philadelphia chromosome that we talked about, which is a bad prognostic factor, you can use drugs that target that specific mutation, such as dasatinib or nilotinib or imatinib, which are also the drugs used for CML. So if any of the factors that we discussed early for being high risk are present, then even though you can give them induction and consolidation and it looks like they're fine, with these high-risk factors, the chance of them relapsing is very high. So sometimes instead of doing a full consolidation and maintenance, you follow up with a stem cell transplant in order to develop someone else's immune system to help fight the tumor in your bone marrow for the rest of your life. This comes with side effects, but potentially is one of the only curative options for people with high-risk ALL. Younger patients do better, and what we found is that those young teens, if you give them the regimens which are more like that given to children at St. Jude, they tend to do better, but they're very difficult regimens because a 7 or an 8-year-old can handle chemotherapy much better than a 60-year-old. A 20-year-old does pretty well, but it's still difficult. The chemo regimens are extremely complicated, and they often add drugs called asparaginase, which do have some side effects that you have to watch closely for in older patients. So if you got an older patient, this isn't going to go well. Oftentimes, that's why for all patients we should be considering clinical trials, but these especially. But if they have to be a very fit elderly patient, they can receive the intensive chemo and potentially stem cell transplant. So we just went over ALL. It's not the most common disease, 6,000 per year in the U.S. This was 2013. Many of these are the elderly patients that will be passing away. It's intensive treatment. So next we're going to talk about AML, which has some of the similar factors for being acute and need to be addressed quickly. So you saw the incidence earlier of most of the patients that have ALL are young. Most of the patients that have AML are old. These are, you can see the ages of 80 to 84, where a large percentage of patients develop this. This is SEER data from the United States. So just like for ALL, you have testing, which includes bone marrow biopsies. For AML, usually there's no CAT scan required. Talking about the lumbar puncture, it would only be necessary if patients had extremely high white blood cell counts. And actually, you would wait until the white blood cell count came down before you did the lumbar puncture, because you wouldn't want to have a bloody tap where, when you're doing the lumbar puncture, blood with leukemia cells would seep into the space around the spinal fluid and basically develop leukemia around the CSF. So for these patients, you usually wait till the blasts are gone and do a lumbar puncture for patients that have very high white blood cell counts. But in general, for AML, you do a bone marrow, you check the same cytogenetics that we did before, but these have different mutations than ALL often have. And they also have these other markers, which are, they're called molecular markers, and they're not large chromosomal abnormalities. They're small mutations in DNA that they found that are prognostic. So there's poor, intermediate, and good risk AML. So patients that have these mutations are the good risk types of AML patients. The ones that have the translocation 821 and inversion 16, these are often, the 821s do really well with chemotherapy, and also the 16 and translocation 1616 as well. What's not up here is the APL, which are the 1517 translocations. Those are the APL, or acute promyelocytic leukemia. They're often treated completely different with arsenic and ATRA, and they do extremely well. These do well with standard chemotherapy. The intermediate risk can be treated with chemotherapy. They can go into remission, and they have an intermediate risk of relapsing. The poor risk, which have complex cytogenetics, in this situation it's more than 3 abnormalities, or an 11q23, or some of these specific ones, do very, very poorly no matter what. And these are often the patients that we're definitively sending for stem cell transplant if we can get them into remission. So many patients end up having a normal cytogenetics, or their DNA looks normal. So what they started doing is looking deeper for these mutations. So if a patient is normal, but they have an NPM1 mutation, that moves them up to the good risk. Or if they have an 821 translocation but have a c-KIT, that moves them down. And if they have a FLT3, then that moves them down to be more poor risk. And I'll show you what that means on the next slide. So just think of poor, intermediate, and good risk. So here you see how long people live. So when you start, 100% of the people are alive, and going out 2 years, 4 years, and 5 years. So this is the poor risk that we talked about, or adverse risk. And this is, you can see how, so at 2 years, you can see that 90% of the people have died. whereas for favorable, it gets to around 50%. So I know that's not the most favorable thing you've ever heard, but for them, this is considered good. And the intermediate is in between. So if someone had normal cytogenetics, normally they would be here, but if they had that NPM1 mutation, then they would move up to this favorable risk group. So these patients we always send for transplant. These we don't usually. And these, it's a decision that you have, but actually they usually do better with a stem cell transplant after they can get it placed into remission. That's why it's so important when we first do a bone marrow biopsy to make sure before a patient is treated that they're tested for this FLT3, NPM1, c-KIT, and CEBP alpha, those 4 tests, because you won't know if someone is down here or up here, and it will really affect. And after they're originally given chemotherapy, you won't be able to get that information back. So basically, I think I said most of this over here. It's similar in that you receive induction chemotherapy and then followed by consolidation. So induction is usually called 7+3, and you give cytarabine, which is a chemotherapy. It's always given in the hospital, just like for the ALL, and you get 7 continuous days of cytarabine infused as a drip. And then the anthracycline is given for 3 days in a row, and that's usually idarubicin or daunorubicin. So the goal for this induction is to make the leukemia cells disappear so you don't see them anymore in the bone marrow. And that would be being in remission or being in a complete remission. That's also the goal for the ALL patients, but sometimes it takes longer for them to go into remission. So basically, after you give 7 and 3, on day 14 of them being in the hospital, you do another bone marrow and you see if all the leukemia is gone or all the blasts are gone. So I talked a little bit earlier about the specific subset of patients that have APL. What they found is they actually can give pills or drugs, Atra, or an infusion, arsenic, which are not really chemotherapies, but they target just this mutation and cause the cells to mature. Sometimes you add on a little chemotherapy with it, and these patients tend to do extremely well. So the main thing to be aware of and concerned with APL patients is when they are first diagnosed, they have an extremely high risk of bleeding and clotting to the point where usually if they're going to die, they die within the first week or 2 before you can start these drugs because they have a bleeding episode. So the sooner you can start Atra, which is a pill, the quicker they will stop their issues with bleeding, or DIC type picture. Once you start this, all their leukemia cells start growing, maturing, and as a result, sometimes their white count will actually shoot up instead of going down, and the patients can get short of breath and have problems. And this is called differentiation syndrome, because the cells are growing like they're supposed to, but they all happen at once. And the patients can be very sick from this. Usually the treatment is steroids and sometimes some chemotherapy to knock the white blood cell count down. So those are the basics for how we treat fit AML patients. If a patient is older and you don't feel like they could handle this intensive chemotherapy, and let me just say that this chemotherapy will make your white blood cell counts go low for sometimes 3 or 4 weeks, which is why patients are in the hospital. They're at high risk for infections and could at any time develop a severe infection with sepsis, so we watch them closely. Since some older patients couldn't tolerate that, we have other drugs called decitabine or azacitidine, which can be given sometimes as an outpatient. They will not cure patients, but they're much more tolerable, and they will oftentimes help them live longer if they can't tolerate other drugs. For the first time this last year at our meeting for hematology, they did find a new drug to add, and it was for FLT3 positive patients that usually do poorly, and it was a FLT3 inhibitor, midostaurin, and it seemed to work. I mean, it improved survival by several, roughly 5 percentage points, but it was the first drug added in some time that seemed to definitively help. So it's not yet FDA approved. So when we talked a little bit about stem cell transplant, we talk about typing and who can be donors and who can't. So this is real quickly, when we talk about someone's immune system, are their HLA, that's like what their white blood cells look like, and the rest of their cells, what their immune system sees. You get one chromosome from mom and one from dad. So dad has 2 separate chromosomes that he inherited. Mom has 2 separate chromosomes, and this is chromosome 6 specifically. So each child will get either chromosome red or blue from dad, and they'll get either pink or yellow from mom. And so there's basically a 25% chance of getting any specific haplotype or combination. So whenever you ask someone about finding out if their sibling is a donor, there's a 25% chance that each child of siblings will have the same haplotype or same chromosome from mom and dad so that they could donate to one another. And that would be a 10 out of 10 match. Sometimes you get half from mom and half from dad, so you can see parents and children will always be half matched, and that would be a haploidentical transplant. That's done differently, but usually when we talk about someone being a 10 out of 10 match, you can see why it's a 1 in 4 chance that a sibling will be a match, and why an aunt or an uncle or someone else have almost no chance of being a match because of this unique way that the distribution occurs. So going back, we'll go now to chronic myeloid leukemia. It's completely a blood cancer. It does not have any distribution in lymph nodes. For many years, it was the most common reason that we would do allogeneic stem cell transplants. It has the same mutation that we talked about, the Philadelphia chromosome, a 922, which causes a BCR-ABL. Usually the patient can present with an elevated white blood cell count. Sometimes their platelets are elevated as well. Their spleen can sometimes be enlarged, and they might feel fine when it's originally diagnosed. Sometimes patients' white blood cell count might be 20,000 or 30,000, and they don't really have any symptoms. If we send the blood for this test, we'll end up needing to do a bone marrow biopsy, but you can also send peripheral blood initially. And you find this 922 translocation, and it's a myeloid leukemia, then they have CML. So this is how it's staged. The chronic phase ones in the bone marrow have a low percentage of blasts. If you have CML long enough, it will oftentimes progress from chronic to accelerated phase to blast crisis. And when this happens, it's no longer a chronic disease. Chronic, we talked about being better, slow, indolent, and this basically is like acute myeloid leukemia. So it's often much better to start treatment on patients in chronic phase. So the first drug that got approved was imatinib several years ago, and it was groundbreaking, and that these patients basically went from living several years without a stem cell transplant to living as long as the drug worked, which was sometimes 20 years plus. And you can see that after imatinib came out, it changed everything, and there were only just a few hundred patients dying each year of those 6,000 that were diagnosed. They did develop second-generation drugs. One is dasatinib, and another is nilotinib. I just picked out one graph from one of these studies to show you. This is the percentage of patients that develop a major molecular response. Basically, the CML disappears completely where you can hardly see it in the blood at all. And when that happens, this is imatinib, newly diagnosed patients, and this is nilotinib at different dose levels. So basically, nilotinib will more frequently make it all go away. We know that some of the patients where it doesn't completely go away, so these do better than these. Some of the patients where it does not completely go away, they will develop resistance and the leukemia will come back. So you would much rather have a drug that worked better. But this drug is more expensive, it's newer, and has different side effects. So one of the ways that we approach it is, one of the recommendations would be you can just start with nilotinib or dasatinib, these second-generation drugs. The actual improvement to your overall survival is questionable. Even though it looks like it doesn't get as deep a remission, these patients usually live almost as long as these patients. So what they found is if you start with imatinib and you get a major molecular response, just stick with it. But if after a few months it doesn't, then quickly change to one of these second generation drugs. You don't lose any of the ability to have a good response, and it's less expensive, and patients usually tolerate it better. So what they found several years ago is the general consensus was CML is not curable. As soon as you stop the pill, it comes right back again. But the longer they treated these people, some of them developed these deep remissions, and a 4.5 log reduction, a log reduction would be dropped by 10, so drop from 1 million to 100,000 to 10,000, and to 4.5 levels down, where you don't detect any signs of the CML. They followed these patients for many years, and so they started thinking about, well, some of these possibly cured, and so they started stopping drug for these. And when they did that, about 40% of them, the leukemia after 7 years has never come back. Although this is not the standard of care, we think that some of these patients may be cured, or maybe their immune system just controls those few cells, so that after, if you get a complete 4.5 log reduction in some of these patients, PCR for BCR-ABL, it might be considered in the future an option to stop the drug and just watch them closely. And if they do start relapsing, you can just start the drug back, and they usually go back into remission. So that was ALL, AML, and CML, and finally CLL. Although it's a leukemia by name, it really follows under the non-Hodgkin's lymphoma grouping, and you can see the number of cases and incidence of death. When we're talking about lymphomas now, in the lymph node is where these develop, as opposed usually to the bone marrow, but sometimes we still look in the bone marrow to find evidence of these different types of lymphomas. So of all non-Hodgkin's lymphoma, the most common is diffuse large B-cell, the next is follicular, and CLL is actually less common. And you can see this is a germinal center, this is part of the follicle of the lymph node, and this is where these get their names. Diffuse large B-cell, these cells look large, like larger than the other surrounding cells. These are in the follicle. And actually, if you look, hopefully you can see this, as a cell matures and marches on, it can receive a mutation anywhere along the way, and depending on where it goes bad, it depends on what kind of lymphoma you develop. So if it's in this type, after it's in the centrocyte stage, it'll most commonly develop a follicular lymphoma. But as these cells mature in the marginal zone and they develop a mutation, those are the marginal zone lymphomas, all the way down to multiple myeloma. So this is why different lymphomas are different and behave differently. So when you're thinking about lymphomas or non-Hodgkin's lymphoma, the way I like to break it down is using this chart. Just like the acute and the chronic leukemias had some that were indolent or slow growing and some that were aggressive, it was the same for them. The AMLs and ALLs, although aggressive and life-threatening, they grow fast, but they're curable because the cells are growing so quickly. When you treat them with chemotherapy, you're killing off the fastest growing cells, so you can actually cure them. But if you don't cure them, they come back and they can be very serious and life-threatening. Whereas the indolent grow very, very slowly, and usually they're very treatable. They don't usually cause problems for a long time, but no matter how much chemotherapy you give, they grow so slowly that you're not curing them. It would take so much chemo to kill them completely that it would hurt the person. So these are usually not curable but very treatable. So where that cut point is has to do with somewhere along where they're Ki-67, which is usually the percentage of cells that are dividing when you look at them under the microscope. So for a Burkitt's lymphoma, 95% of them are growing. These can grow overnight. They can double in size. Oftentimes you can cure them, but you have to treat them very quickly. Diffuse large B-cell, somewhere in here. Follicular lymphoma is more on the non-curable side. Some of them are a little more aggressive and look more like a diffuse large B-cell. Marginal zone and CLL, these are usually the slowest growing. And you usually treat them and then watch, and then they come back and you treat them again. So when you stage a non-Hodgkin's lymphoma patient, you want to look at what sites are involved. It's a little different than lung or breast cancer. And in the same way, CML and AML, they had different types of staging. They were more prognostic factors. But for lymphoma, if you had one single set of lymph nodes involved, that would be stage 1. If you had 2 sets or more on the same side of the diaphragm, both above or both below, that would be a stage 2. If you have lymph nodes above and below the diaphragm, that would be stage 3. And then if you have bone marrow involvement or other organ involvement like spleen or liver, then that would be a stage 4. And usually it's stage 3, and you can have A or B, and B would mean they have B symptoms, such as weight loss, unexplained fevers and sweats. And when they say weight loss, it's usually like a 10% weight loss over 6 months. So when we're looking for lymphomas, the more aggressive ones, the faster growing on our chart, usually need a PET scan. And that's because they're growing quickly. They'll take up the radioactive sugar, and you can see how bright that is compared to the surrounding organs. To diagnose a lymphoma, a small fine needle aspirate or a very small biopsy is usually not adequate because these lymphomas all look alike. So it's hard to tell the difference in a CLL versus MALT lymphoma versus a diffuse large B-cell with just a few cells. So usually you need a big core biopsy or take out a whole lymph node, have a surgeon take the whole lymph node out for the pathologist to look at it under the microscope. That's the best way to make the diagnosis. So specifically for diffuse large B-cell lymphoma, this is a paper that looked at something called your IPI, or International Prognostic Index. So you have a stage, 1, 2, 3, or 4, A or B, and then you have subsets of how patients do. So you kind of get a point for each of these, having higher stage as a point, an elevated LDH, age, multiple sites outside the lymph nodes, and ECOG performance status is just how strong. So if you have a poor performance status, then you get a point. 0 to 1 point, you can see your risk of 5-year survival is 73%, and 4 or 5 points, your risk is only 26%. So pretty big distribution for how people do based on their IPI risk score. Doesn't change how we treat them usually up front, but it helps us manage expectations on how they're going to do. So the most common chemotherapy that we give for non-Hodgkin's lymphoma is R-CHOP, if you've heard of it before. CHOP are the 4 chemotherapies, and although the letters don't quite make sense, you have cyclophosphamide. The O is actually for vincristine, prednisone, and then daunorubicin. And so you have these different dosages, plus rituximab, a monoclonal antibody. They've tried giving it every 14 days or 21 days. Right now we mainly give it every 21 days because there's not much benefit in giving it in a dose-dense fashion like we do breast cancer patients. There are maxi-CHOP and there's also mini-CHOP, giving it a little stronger if needed or a little weaker if needed for older patients. And you can see it's given every 3 weeks, usually for 6 cycles for the aggressive lymphomas. So I talked a little bit about Rituxan earlier, and it was just like Gleevec or imatinib was the poster child for targeted therapies with CML. This is the same for lymphomas. So they developed an antibody that normally your body makes naturally, and these are the sticky ends of your immune system where they attach to the flu or some other infection. And this end is like the signaling to get your own immune system to attack something. So if this was the flu, an antibody that your body would make would stick to it and get your immune system to attack it. And what they did was they created an antibody that would stick to the lymphoma cells and get your immune system to attack it. And that's basically how most monoclonal antibodies like rituximab work. So this is a situation of a cat. Here's an example of a CAT scan. And this is a slice, and this is their spine. their ribs. This is part of their liver. And you can see this mass here is the lymphoma, and this is before, and by giving R-CHOP, you can see almost nothing left behind here. So it's a dramatic response, and oftentimes these patients do respond really quickly to treatment. And you can imagine why we worried about tumor lysis earlier. If all these cells are dying at once and they're releasing their potassium and other things into the bloodstream, you have to be careful and hydrate them, make sure they're on allopurinol. So here's an example of a patient. We'll take through a case. They're a 65-year-old woman. She was feeling well, except incidentally noted she had a lump on her chin. Looking over her past medical history, she had hypertension, she's widowed, a cousin with breast cancer on minimal medications. You can see, looking at her blood counts here, her hematocrit was normal, platelets were normal, kidney function and calcium were normal, liver tests were normal, and her white blood cell count was 71,000 in an asymptomatic patient. So I'll give you a second to think about what you think it is. So in this situation, the patients, we sent their blood for flow cytometry, and when they looked at it under the microscope, they saw these cells that all looked exactly identical. These are all lymphocytes, and this turned out to be chronic lymphocytic leukemia. And when they looked at it under, this is the flow cytometry report that you would get. So 92% of the cells were lymphocytes, and they all looked similar. It says they were B lymphocytes. They had CD19 and 20 on them. 20 is what rituximab attaches to, and they were clones. They were all identical, and so this was consistent with CLL. And then sometimes they're called SLL if it's just in the lymph nodes and not in the bloodstream, and that's the difference, but it's the same process. So in this situation, if you do a PET, you don't see anything. This is the brain and this is the bladder, so they're supposed to have increased uptake, but there's no bright spots. The slow-growing indolent lymphomas don't usually light up. They're not growing fast enough to show up on PET, so usually a PET's useless unless you're worried that they may have switched to an aggressive lymphoma. The lymph nodes are relatively small, and this patient didn't really need any treatment. So for CLL, chronic lymphocytic leukemia, which is actually, like I said, part of the non-Hodgkin's lymphoma, many years ago, this was even in 2011, the treatment was 3 very strong chemotherapy agents, fludarabine, Cytoxan, and Rituxan. And these are the overall survival of patients that got 2 drugs or 3, and by adding Rituxan, you can see how these patients lived longer. 47 months versus 21 months was the average. But if you remember this chemotherapy regimen, it was extremely immunosuppressive. Their white blood cell counts or sometimes platelets would go down for months and months and months at a time. So when the patients did well, they did great, but oftentimes you were fighting infections for extended time periods with this regimen. So this was the strongest chemotherapy regimen they could come up with and was the standard for several years. When you look at the patients that were treated, these are the ones that had a complete remission. It went away completely on their CAT scan, and they're the ones that lived the longest. The ones that it only partially went away, obviously as you would expect, they did worse, and the ones that didn't respond at all did the worst of all. This is a breakdown based on the way their DNA looked under the microscope. So patients that had a 17p deletion, you can see their survival, how horrible it is. 100% of them dead at 2 years. And so in those groups, this FCR, this extremely aggressive chemotherapy, did nothing for them. So they got all the side effects and really no benefit from that. So they had to come up with some new drugs. So one of the drugs they came up with, just like Gleevec, was a tyrosine kinase inhibitor, which means it fit in. This is the cell surface. This is on a receptor on the cell, so it gets signals and it sends them inside the cell to tell it to grow. And this is a complicated process, but basically for ibrutinib, this new drug, it blocks this BTK inhibitor. All right, it's the Brutus tyrosine kinase. If you heard of Bruton's agammaglobulinemia, it's a patients that's born with this mutated and they don't make any antibodies. So the drug blocks this, and shuts the cell down. And so a New England Journal of Medicine paper came out for CLL. The good thing about this was even those patients that had the 17p deletion that looked like they did horrible with FCR, they're able to take this pill and do amazingly well. Although it won't cure these people, the patients did excellent. And so this drug is approved either second line or front line if you have a 17p deletion. There's newer drugs like Adalasib, and it works in the same way. It's more of a targeted drug. It's a PI3 kinase inhibitor, and it's not on the cell surface, but one step down, it blocks it and basically shuts down the cell. It also has been approved with Rituxan in patients with relapsed CLL. This is just from a couple of years ago. So these are two pills that we have in addition to the strong IV chemotherapies. Some other regimens you may be familiar with for CLL, it's a crowded space. Bendamustine, it's an IV chemo that's not quite as strong as R-CHOP or FCR. It's a little bit in between. It can be given with Rituxan. It's just two drugs. Your hair doesn't fall out, and you can get some excellent responses. But it still can be myelosuppressive. And then also for elderly patients, obinutuzumab is a next-generation Rituxan. It's CD20 antibody, but it's engineered to be more effective. And they found amazing responses in these patients, better than just Rituxan alone or chlorambucil alone, a really weak chemotherapy pill. So we have lots of options for the weak and infirm or very healthy young patients. So CLL is not curable but treatable, and now we have a long list of medicines to use. The usual course of action for CLL is you treat them, they go into remission for several years, and then they come back. When it comes back, you treat them again, and oftentimes the next time around, the drug doesn't work quite as well. You can see how after several cycles, the patient will be relapsing faster and faster, and it actually could eventually become life-threatening or problematic. Here's another patient, JW, a 60-year-old gentleman with hypertension and diabetes. He moved from Chicago to be near his family. He had been smoking a pack per day for 30 years. His family has some sort of bone cancer. He was on a couple of medicines for his diabetes, and he actually presents with acute renal failure and went on dialysis when we first met him. His white blood cell count you see was here, fairly normal. He was anemic. His calcium was normal. His creatinine while on dialysis was elevated. He ended up getting a biopsy, and he had casts of this IgA kappa protein in his kidney. On testing his blood, he had a monoclonal protein, and he had an elevated IgA level floating around in his bloodstream. Normal is up to 400, and his was 2,000. There's a more specific test called a kappa-free light chain, and it was elevated. So if you don't know, this would all go along with multiple myeloma. So this patient was started on chemotherapy with Velcade and dexamethasone, and actually his kidneys got better. He actually came off dialysis and improved. So for multiple myeloma, this is the 5-year survival back in 1950, around 10%. It gradually improved up until the 90s, and then when the drug thalidomide was approved, you can see how the survival curve dramatically improved. And in the last several years, there's been more than this, but all these drugs became approved. And with them, patients are living longer and longer. Thalidomide has a class of drugs, including Revlimid and pomalidomide, that are out, and bortezomib and carfilzomib are both proteasome inhibitors. So when we talk about a monoclonal protein, some people may wonder what that means. You take someone's blood and you run it through a gel with electricity through it. The heavier ones slow down and the smaller ones go faster, and you end up getting this picture, are these spikes. So this is their albumin, and these are their gamma globulins, and this is where all their antibodies are. So this would be a normal patient, and then someone with multiple myeloma would have a spike or a monoclonal protein here, and that would be indicative of there being a problem or them making all of one type of antibody. So when we talked about antibodies earlier, remember this is a normal antibody. there's a heavy chain and a light chain. So when you're checking someone's immunoglobulins, you're checking how many of these they have. There's IgA, IgG, and IgM, 3 different kinds, and you can measure them. And usually someone has an IgA, multiple myeloma, or an IgG, that's that clone. And then there's these light chains, and for a patient, they're either kappa or lambda light chains, and they just make either one or the other. And so normally there's a distribution of kappa and lambdas of a 2-to-1 ratio. So if they have a whole bunch of IgA and a whole bunch of kappa, you know that there's a clone, a plasma cell clone in their bone marrow where they're making one specific kind, and that's basically what's causing their multiple myeloma. So just for like AML, where we would have to do a bone marrow biopsy, to diagnose multiple myeloma, you have to do a bone marrow as well. And in the bone marrow is where you look for these plasma cells, or the myeloma cells. So if several patients are walking around with some plasma cells in here, very, very few, that are making a monoclonal protein like we talked about on the previous slide. And these patients are called MGUS, or monoclonal gammopathy of undetermined significance. Basically, they're making a small protein in their blood, but they don't have multiple myeloma. And the way this progresses is you start out with the protein level, which I'll talk about in a minute. As it grows with time, this is not a cancer, but as it grows with time, the plasma cells take over the bone marrow, and when they get above 10%, you'd officially have smoldering myeloma. This isn't still a reason to treat. You don't treat until these grow to the point where they start causing collateral damage in your body, and that would be damaging organs. And the acronym I use is CRAB. It can make your calcium go up, renal insufficiency, make your kidneys abnormal, like go on dialysis, anemia, make your blood counts low, or cause lytic bone lesions. And so if you have 10% plasma cells in any one of these, and there's not another cause for them, like you're not anemic from iron deficiency, then you have multiple myeloma and you should be treated. So when we talk about lytic bone lesions, I don't know if you've seen an example of this before, but here's a CAT scan, and this is a normal spine. And you can see these are where the discs are, and these are the spinal processes. And what happens is a patient will get holes in their bones, develop lytic lesions from the myeloma, and then they weaken, and just normal life, these can cause compression fractures. And you can see this poor patient that has multiple compression fractures, probably lost a foot of his height from all these lesions, and they're very painful. And so these are what are treated with kyphoplasty, if you know it, interventional radiology. They'll put a needle in here with a balloon and expand this area and fill it with cement so that it's stabilized and they don't have as much pain. This is why we give Zometa, to try to protect bones from having fractures from these lytic lesions. But the main treatment is to treat the myeloma so that you don't develop new lesions. So a patient that has MGUS that I talked about earlier, they have an abnormal protein in their blood but nothing else. And this is extremely common to the point where they started finding it more and more in around Mayo Clinic, the whole county. They checked 1,100 patients. They just checked their blood at random. And what they found is about 5% of them had, over the age of 60, had a monoclonal protein. And if they followed them long enough, about 1% per year would progress to multiple myeloma. Some of them would also progress to other lymphomas like amyloidosis or Waldenstrom's or CLL. So basically, if you have a monoclonal protein, you're at increased risk of one of these developing, and so you should be watched, but it's not a true cancer. Most of those patients will live a whole life and never develop any type of leukemia or lymphoma. So the staging system for multiple myeloma is simple. There's an older system called the Dury-Salmon, but the newer one is the ISS. And all you need is a beta-2 microglobulin and an albumin. If the beta-2 is low and the albumin is high, it's a stage 1. If the beta-2 is high, it's a stage 3, and anything in between. So please, if you ever have a newly diagnosed suspicion of multiple myeloma patient, check a beta-2 microglobulin before you give them chemotherapy, because afterwards you won't be able to test this and know what their original stage was. And if they're ISS stage 1, their overall survival was 62 months, and stage 3 was 29 months, although these are better now with newer drugs. Just like with AML and ALL, if you do a bone marrow on a patient, they have different cytogenetic abnormalities. You see a trend here on how this all works. They can have standard, intermediate, or high risk, and just like a 17p deletion was bad in CLL, it's also bad in multiple myeloma. So the chemotherapies we use are varied for multiple myeloma. VRD is Velcade, Revlimid, and dexamethasone. This is Cytoxan, Velcade, and dexamethasone, and all these different regimens. And you can see this is the response rate, and it's 100%. So basically they're saying 100% of people, the drug will at least work some. And this one being 88 and 100, this is just luck, but they do very, very well. A CR would be it going away almost 100% where you don't see it. So in 44% of patients, the myeloma disappears completely. But just like the indolent lymphomas, there is no cure for multiple myeloma. So the way we think about it is you give them chemotherapy, and the number of plasma cells in their bone marrow will decrease, hopefully to the point where you don't detect any proteins or any myeloma cells at all. With just Revlimid, you would get at least a very good partial response or a 90% reduction. Sometimes we'll do a stem cell transplant to get a deeper response. In the past, we might do 2 transplants, but now we usually will just do 1 and maybe give a little more chemo. With the goal to be a stringent CR, we don't see any signs of the myeloma. We know these patients, if you can get it down here, will do the best. They'll live the longest, sometimes up to 10 years with no evidence of their myeloma coming back. And by putting them on a maintenance after a transplant, like a Revlimid pill, you can extend the time period that they are in remission. So these chemos are completely different than the drugs used for myeloma and other lymphomas. Proteasome inhibitors, carfilzomib and Velcade, are 2 of the drugs that have extremely great efficacy. They work even in patients that have the bad risk cytogenetics and in ones where other drugs don't work. They're fairly well tolerated. The main side effect of Velcade is neuropathy or burning and tingling in the fingers and toes, whereas carfilzomib, the next generation, doesn't have that same effect. The monoclonal antibodies that we talked about, Rituxan and obinutuzumab, there's also some specifically for multiple myeloma. Recently approved is elotuzumab, and it actually targets something called SLAM7, and it can be given in conjunction with Revlimid and dexamethasone in the treatment for multiple myeloma patients. A newer drug is called daratumumab. It's a monoclonal antibody that attacks CD38 on the surface of the myeloma cells. It has some interesting side effects, since CD38 is also on red blood cells. It can mess up typing. So if you have a patient on daratumumab, it's best to get a type and screen before you give it, because afterwards they'll always have an indirect Coombs positive. And it does cause problems. You should always let the blood bank know if you're transfusing a patient that's been on daratumumab, because it will mess up their testing. They're still able to get blood, they just need to know about it. So in conclusion, just to review, leukemia, there's chronic, acute, and lymphoid and myeloid, but the CLL actually falls under the non-Hodgkin's lymphoma. For this, you can give a pill oftentimes. These are induction chemotherapy followed by consolidation and often maintenance. There are specifics. If this one has the same mutation as this one, the 922, then they get the dasatinib or imatinib. For AML, newer drugs are coming out. Oftentimes, these patients both require allogeneic stem cell transplants. These are slower growing. CLL is often treated with multiple chemotherapies or sometimes pills and continually relapse, but are often, they live an extremely long time period. For the lymphomas we talked about, there's aggressive. They grow extremely fast. Patients can die quickly of them and have to be in the hospital receiving chemotherapy quickly. Then you have lymphomas, which you would treat with R-CHOP or some combination of drugs similar to that. They're often curable. If they have different mutations, a c-MYC or a BCL2 mutation, they would fall into the double hit, and they tend to do worse. Follicular lymphomas are on the indolent side, non-curable. You treat just like you would CLL. They go into remission, and they come back. Most of these are treated with the similar drugs like bendamustine and Rituxan. Thank you for your time. That's it.